Hello viewers, thank you so much for joining me on this channel. I have been extremely overwhelmed by the response I have received to my videos. Thank you so much for watching them. I hope I have been able to help you. I don't fully understand why you watch my videos. Do you watch them for the travel videos? Do you watch them for the practice videos? Do you watch them to familiarize yourself with how to make the transition from working in India to working in the United Kingdom? It will be very helpful if you could point it out by mentioning it in the comment section below. With that out of the way, today's video is part of the widely popular Practice with Puspen session. I have talked about various different scenarios in the Practice with Pushpen episodes. I've talked about history taking, I've talked about breaking bad news, and I've also talked about informed consent. What I have not talked about is how to give an explanation. In today's video, we will discuss giving an explanation, which basically means explaining a diagnosis and the plan of treatment to a patient. Today's clinical scenario is benign paroxysmal positional vertigo, and once again, we will practice with Dr. Pritha Ghosh, who is a very renowned ENT doctor in India, and she will soon appear in MRCS ENT OSCE. She has sportingly agreed to practice with me, and she has also given me permission to both record and upload our practice session on YouTube for the benefit of all of you viewers. If you, the viewer, want to practice with me, please get in touch with me by mentioning that you're interested in the comment section below, and maybe we can set up a mutually convenient time and we can practice on Zoom. With that out of the way, let's discuss what is the difference between giving explanation and breaking bad news, and also let's talk about a brief overview of the entire MRCS ENT process. MRCS ENT for the uninitiated consists of two exams, MRCS Part A and MRCS ENT OSCE. Why should you even bother about MRCS ENT? I have made a video talking exactly about that. I'll leave a link to it in the description below. MRCS ENT is basically an exam which helps you become a member of the Royal College of Surgeons through the ENT route. Now, there are 4 Royal College of Surgeons, one in London, one in Edinburgh, one in Glasgow, and one in Dublin. So, not only do you become a member of the Royal College of Surgeons in the United Kingdom and the Republic of Ireland, you also can choose to go to the UK and work as a doctor once you have become a member. I have explained the entire pathway of how to go to the UK to work as a doctor through the membership of Royal College of Surgeons route, and it's an 18-step process, and I have made videos talking about the entire process as well as each individual step. I'll leave a link to those videos in the description below as well. So just to recap, MRCS ENT involves 2 exams, MRCS Part A, which is a multiple choice question exam. It consists of 2 papers, a 3-hour paper 1 and a 2-hour paper 2, separated by a 1-hour lunch gap. Both papers should be taken on the same day, and they can be taken from centers in India. These are multiple choice question exams, as I mentioned, 5 options, single best answer, and they largely deal with basic sciences topics and other general surgery topics. I've made a detailed video talking about how to prepare for MRCS Part A without coaching. I'll leave a link to it in the description below. Once you have passed MRCS Part A, you get 6 attempts to pass MRCS Part A. Once you have passed MRCS Part A, you then have to take MRCS ENT OSCE. MRCS ENT OSCE, however, cannot be taken from India. In fact, it has 2 parts, non-manned exam and the manned exam. These are basically 2 halves of the same exam. The non-manned exam can be taken from a laptop, so you can take it theoretically from India, but the manned exam has to be taken from either London or Edinburgh or Glasgow or Dublin. Where the manned exam will be held depends upon the rotational pattern that the Royal Colleges have decided among themselves. You can actually predict the rotational cycle and predict the venue of the exam. I have made a video talking about how to predict the venue of MRCS ENT OSCE manned exam. I'll leave a link to it in the description below as well. So manned exam is where the clinical skills are assessed. Clinical skills involves both clinical examination as well as communication skills, how you communicate with the patient. Whereas the non-manned part of MRCS ENT OSCE is just about clinical knowledge. So you'll be asked questions and you have to type in the answers on the laptop. So coming back to the manned exam, communication skills and clinical examination are assessed. And this is the description of the MRCS ENT OSCE. As you can see, 400 marks are allotted to the non-manned exam, which is just about clinical knowledge, and 120 marks is for the manned exam, which again has to be taken from the UK or the Republic of Ireland, depending upon where it is being held in your session. And manned exam consists of clinical examination and communication skills. In terms of communication skills, you can either encounter history taking, where you'll be asked to obtain history from a patient, or you can get a breaking bad news station where you'll be asked to explain a bad news to the patient, or you can be asked to obtain informed consent for a surgical procedure, or you can be asked to give an explanation regarding a particular disease. Now, it is very important to remember that you cannot know in advance what you are going to get. You don't know if you are going to get a history taking station or a breaking bad news station or an informed consent station or a giving explanation station. What you do know is you have 7 minutes to finish the task, and you will not be allowed to look at your watch. You will not even be able, you will not even be allowed to carry your watch to the station. So you will not be aware of the time while you are performing the task. So it is very important to practice communication skills repeatedly. That is where the practice comes in. If you practice the communication skills repeatedly, you don't have to worry about finishing the task within 7 minutes, because finishing the task within 7 minutes is very important. And again, you don't get to look at the watch, so you can't expect to be able to do it without practicing. It's not very easy to finish it within 7 minutes when you're not aware of the time that has elapsed. Again, it's important to know that the time allotted to you will be fixed at 7 minutes, but the task may not be as simple as just obtaining history. It can be a composite task. For example, in the same station, you might be asked to obtain history and then take informed consent for a surgical procedure. For example, a patient has complaints of sore throat. Obtain history and then obtain informed consent for tonsillectomy. That is a composite station where you are expected to take history as well as obtain informed consent for a surgical procedure. The total time remains the same. So again, practicing is what helps you develop the required ability to finish the task in 7 minutes. So this is just one part of manned exam. This is the communication skills part. There is also the clinical examination part, where you'll be expected to perform a clinical examination, like say flexible nasoendoscopy or ear examination or nose examination or cranial nerves examination. So this is what constitutes manned exam. In manned exam, you are supposed to communicate or perform a clinical examination on a simulated patient, basically an actor. And the examiner is going to observe you performing the task. Examiners usually do not interrupt you. They do not ask you any questions. They silently observe you. If you're going completely off track, they might intervene. Otherwise, they don't. So it's just you dealing with a patient, and you should get into the mindset that you are in a clinic where you are talking to a patient. If you can think like that, then it becomes much easier. Now, one of the more common confusions that examinees had, and even I had, was the difference between breaking bad news and giving explanation. The reason why there was confusion is because we always tend to focus on the task at the end. Okay, just focus on the task at the end. If you just focus on the task at the end, like say obtain history or obtain informed consent, that makes it easy. You understand you are supposed to take history. You understand that you're supposed to obtain informed consent. But in breaking bad news and giving explanation, the task is framed in the same manner. Breaking bad news will also have explain to the patient, and giving explanation will also have explain to the patient. So both tasks are explained to the patient. which one is a giving explanation task and which one is a breaking bad news task is sometimes difficult to decipher. An easy way, in my opinion, to differentiate between a breaking bad news station and a giving explanation station is read the entire task and figure out whether the patient is already aware of their diagnosis or not. If the patient is already aware of the diagnosis, then most likely the station is a giving explanation station. If the patient is not aware of the diagnosis and you are telling them for the first time, then it is breaking bad news, kind of like breaking news. You're telling them for the first time, breaking bad news. It is important to know that the difference, because breaking bad news has a different approach to giving explanation. Breaking bad news has the entire setting, perception, invitation, knowledge, empathy, summary format. I have made a video talking about the template that is required for each of the communication skill stations, the template required for history, the template you should follow for obtaining informed consent, the template for breaking bad news, and the template for giving explanation. I'll leave a link to those videos as well in the description below. So I feel I have been able to explain the difference between breaking bad news and giving explanation. In breaking bad news, the patient is not aware of the diagnosis, and in giving explanation, the patient is already aware of the diagnosis. So with that out of the way, let's get into the practice with Pushpen session for today, where we will practice giving explanation in a situation of BPPV, where I will play the role of the patient and Dr. Pritha Ghosh will play the role of the doctor. So in this situation, we will talk about BPPV. Dr. Pritha Ghosh will explain the disease and the management options. The difference between giving explanation and breaking bad news lies in whether the patient already is aware of the disease or not. That is largely the only hint an examinee gets, because both giving explanation stations and breaking bad news stations have the same task: explain. If the patient knows about the diagnosis from beforehand, then it is a giving explanation station. If the patient is finding out on that very instance, that this is their diagnosis, then it is most likely a breaking bad news. It's essentially an inference that an examinee has to make based on reading the situation. So this is a situation where the patient is already aware that the patient has BPPV, and he has requested another explanation of his disease and management options. This can be described as a giving explanation station. Dr. Pritha Ghosh, you will explain this to me. I will play the role of the patient, and you have 7 minutes as per MRCS ENT OSCE rules. Your time starts now.
Hello, I'm Dr. Pritha Ghosh and I work as an ENT surgeon in this hospital. May I speak with you?
Yes.
Could you please tell me your name and date of birth, please?
My name is Tom Smith and I'm 43 years old.
And how may I address you, Mr. Smith?
You can call me Tom.
All right, Tom. I see that you are having some problem related to dizziness, and I was just wondering, what do you already know about this condition?
So I was told by a colleague of yours that I have BPPV, which I really didn't understand much. So if you could please tell me more about it.
Well, yes, I'm actually here because I see that you've requested another explanation of this condition. So, BPPV is a condition which is non-cancerous, which means it is benign. Paroxysmal means which occurs in episodes. Positional means which occurs due to some position either of your head or your neck, and vertigo is the dizziness. So this dizziness that you complain of occurs because of certain head positions, and it doesn't last for very long, and it is episodic. Am I able to explain?
Yes.
So this is one of the common causes of dizziness in any patient. It is about 1 in 50 people. So our ear is divided into three parts: the outer, middle, and the inner ear. The outer ear and the middle ear are divided from each other by something known as an eardrum. The air sound waves comes from the outer ear to the middle ear and then to the inner ear. But our inner ear, apart from the hearing organ, also has something known as the balance organ. And this balance organ has a fluid within itself, all right, because it has three canals with fluid within itself, and hair cells which actually detect the motion of our head, which help us in our balance while we are moving. And on these hair cells there are some calcium crystals, and due to various reasons these calcium crystals can get displaced from its original position. And once that happens, that leads to this episode of vertigo or dizziness, as you may say.
Hmm.
Am I able to explain?
Yes, but why does this
And
happen?
I'm sorry.
Why does this happen?
Well, it could be because the calcium crystals gets displayed and leads to the movement of these fluids, and the hair particles move, and that gives a sensation, false sensation that our body is moving and our head is moving, and gives us this dizziness.
But why is the calcium crystal dislodged in my body?
It could be due to some infection. There are various reasons. It could be due to some infections. It could be because of trauma. Could be because of some surgery. There are various reasons.
Hmm. Yes, you are making sense because I had an episode of trauma to my head 3 months back, and I've had this
Oh,
every ever.
I'm so sorry to hear that. And did you have to get hospitalized, or was it something serious?
Yes, I was in the hospital for 3 days.
And now, how are you feeling? Are you all right? Apart from this vertigo, do you feel anything else?
No, I'm fine. Thank you for asking.
All right. So we actually diagnosed this by doing a test, which was, I guess, was performed on you, known as the Dix-Hallpike's maneuver, where we did some positioning of your head and your body, and we elicited this dizziness. And the treatment options are, one is a exercise that we'll teach you how to do, which is known as an Epley's maneuver, where we will actually teach you how to position yourself and your head when an attack of this dizziness happens, so that this will help to reposition the calcium particles back to its original position. And 70% of the people or the patients actually are relieved from this problem in the first attempt. And surgery is done very rarely. The people who do not benefit from the exercise that we tell them to do might have to undergo surgery, which is very rare, where we might have to occlude this balance organ. The canal that is problematic is occluded, or the nerve that sends the sensation of the dizziness is occluded. Am I able to explain?
So, what about medicines?
Well, medicines are given just to help you symptomatically. They do not reposition the calcium back to its original position. They just help you with the dizziness. So, if the effect of the medicine goes down, you might have an episode of dizziness again.
Okay. And are there any precautions I need to?
Yes, I would like to tell you that. Do you drive by any chance?
Yes.
And you have a driver's license. So you might have to inform the DVLA, because since these episodes of dizziness are very serious and they can actually cause serious effects, like when you're driving can cause serious harm to you and your surroundings, it is better to inform the DVLA about your condition. And sadly to say, you might have to stop driving until you are cured.
Okay.
And I would advise you to use good lighting at night, and to use aids if there's any chance of fall, and also to avoid being at any height or using any heavy machinery.
Hmm. So, I have to avoid heights.
Yes.
Okay. Okay.
And is there anything in particular that you would like to tell me, you feel I might have missed something that you feel is important?
So, you're telling me the treatment is an exercise, and if the exercise doesn't work,
Yes.
the other option is surgery.
Is very rarely done, but yes, mostly the exercise helps in treating the patient. In about 70 to 70% of the patients really get relief from this exercise.
And if it doesn't get relieved in the first attempt, will you try it again?
Yes, we will.
And apart from this one exercise, are there any other exercises?
Yes, there are other exercises that depends on which, as I mentioned, there are three canals of balance. It depends on which canal has been blocked. That exercise will be done, but mostly the canal which is, I'm sorry, not blocked, which is affected.
Okay.
For
Okay.
that,
That is the time. Very good. You explained most of it very well.